And we've got the wonderful Hugh, who will be taking us through a day in his life. So if you've ever wondered what it's really like to be a doctor, what they really do, how their work week unfolds, for our first session, we have a seasoned doctor, not sure if that's fair, Hugh, but a seasoned doctor ready to tell you all about it. So in the chat, please welcome Hugh, our first speaker for today. Hugh studied medicine at Oxford University between 2012 and 2018. After graduating, he completed his foundation training in Essex before taking an F3 year working in paediatrics, also in Essex. During this time, he realized that he really enjoyed working with children, so he applied to paediatric training and got a training post in London. He's currently a paediatric trainee, and he's recently started a new job in paediatric A&E at Chelsea and Westminster Hospital. So Hugh will be sharing his experiences for the first half of the session. After that point, we'll open for Q&A. So like I said, during the session, if you've got a question that you want to see answered, then please pop it in the Q&A box. You can also upvote each other's questions so that we are answering the ones that you're all really keen to hear the answers to. And we'll run through them with Hugh towards the end. Hugh, there's lots of nice good mornings and hellos coming through for you in the chat, which is great to see.
That's very nice. Thank you. And thank you so much for having me.
Thank you. It's great to have you here. What I'll do is I will spotlight you and then I'll hand over to you to take it away.
Thank you. I've got to figure out how to share my screen.
Yeah.
Yeah, we see it.
Okay. Do you still see it?
Yes.
Yes.
Okay, wonderful.
Thanks, Hugh. Over to you.
Okay, so good morning, everyone. Thank you so much for joining us. So yeah, this is going to be my talk about essentially my career so far, and I'm going to try and take you through a snippet of a day in the life of a doctor who works in paediatric A&E at the moment. So I'm going to do a quick talk about my background, what my day-to-day life is. I'll have a mention of what I would do differently if I could go back in time, have my time again, knowing what I know now. And we'll finish with a Q&A. I'll try and leave a lot of time for the Q&A because I think that's going to be quite an interesting bit, but we'll see how time goes. So why medicine? I feel like this is, when you go for an interview in medicine, this is always the first question that is asked. Why do you want to be a doctor? Why do you want to do medicine? And I think it's a very personal decision. But for me, I'll tell you my story. I was in hospital a few times as a kid, nothing too serious, fortunately, but I was in hospital a few times and I saw a lot of doctors. I saw a lot of good doctors. I saw some not so good doctors, and I saw what a big difference a good doctor can make to someone's whole experience, their whole journey through hospital. And I saw like what a huge impact that can have on somebody. And I was very fortunate in that I was, quite good at science, quite good at maths. And I thought, oh, do you know what? Maybe that's something that I'd be able to do. And I did the work experience. I did the studying, everything. And I was lucky enough to get a place. And yeah, it's worked out very well. So that's just a little bit about why I decided to do what I do. So some more background at school. I'm talking about the British experience a few years ago. I know there's people here from several countries, but GCSEs are what you do when you're 16. So I did English, maths, triple science, the usual, IT, drama, French history. I got good grades, far from the best in my school, but good enough. AS levels are what you do when you're 17, and then A2s are what you do when you're 18. I feel like the system's probably different now, but that's how it was back then. AS levels, very boring, 3 sciences and maths. And then for A2, I dropped physics. And again, I got good grades, but yeah, good enough. Extended project was an interesting thing that we had the opportunity to do, where we had to essentially do some research and plan this. The idea was to produce an essay. It was about 3,000 words. We had to plan it, we had to research it, and we had to write it. And I can't remember exactly what the title of mine was, but it was something to do with coronary heart disease, which at the time was the biggest killer in the Western world. And it was a really great experience to do that. I spoke to some, people who are absolutely leading in their fields. I came down to London. I went to the Royal Brompton Hospital, which is a huge, huge cardiac centre. Spoke to some really, really amazing people. And yeah, that was a good experience of just sort of dipping my toes into the world of research. And I think there's just a little picture of me when I was in school. I look very, very young there. So, work experience, very important if you want to do medicine, because it's all well and good knowing, oh, I love the idea of doing medicine, but it is hard. And I think when you're applying to places, they want to know that you know what you're signing up for, essentially. So, first of all, I did 5 days at the biology department of Lancaster University, and that was useful because it taught me that I don't really want to be a lab scientist, which I'm very glad that I did that. It's important to know. Then I did 2 days at our local hospital in the elderly medicine ward, which is an amazing experience. I did 1 day at our local hospital radiology unit. And then I did 5 days at a local GP. And that was really good. And it really highlighted early on the difference between working in a hospital where you're working in a specialism and you're dealing with a subset of patients, and where you're working in general practice and you see everybody, essentially. So I'm really glad I did that. And then I did a year volunteering at a local care home and a year's paid work in a local care home. And that was, again, a great experience, teaching me what it's like to deal with, potentially quite vulnerable people. Some of them had, poor mobility, some of them had dementia. And yeah, it was really interesting to see how you have to tailor your approach to different people with different problems to care for them properly. And then just a quick bit about extracurricular activities. Again, when you're applying for medicine, they want to know that you're a well-rounded person. So I was the deputy head boy at my school. I did tennis, I did drama, I was in a few plays and musicals and stuff, and I did music. I played piano, guitar, and did choir. And I kept most of those up at uni as well. So as Lavinia said, I studied at Oxford between 2012 and 2018. I'll just break the course down for you real quick. So the course at Oxford is split very clearly into two halves. First of all, you have preclinical school, where you're essentially doing a science degree, which gives you a really good foundation and background in basic science. And then you do clinical school, where you get the chance to apply that science to being a doctor, essentially. So in our first year, we did biochemistry, physiology, and anatomy. In our second year, we did pathology, which is essentially infectious diseases and immunology. We did some more physiology, and then we did neurology. Third year was a great year because we got to choose our own topics, and we did a bachelor's in said topic, and it was great because we got to do a real deep dive and learn from the people at Oxford were literally leaders in their field, and we've got lectures from people talking about their cutting edge research, the amazing breakthroughs they're making and things like that. So I chose to do infection and immunity. And I learned some incredible things about various infectious diseases and, the whole immune system. and we got to do a lot of research. We did a research project where we worked in a lab. We did an extended essay where we essentially wrote an essay on a topic of our choice, which was a great opportunity. And yeah, so I got a bachelor's in infection and immunity. And then clinical school is where you remember that you're going to be a doctor and you see patients. And I think everybody really enjoyed clinical school. I don't remember anyone not enjoying clinical school. It was great. And that's very much on the job learning. You have 1 day of lectures every week, and the rest of it, you're just on the wards, you're shadowing doctors, you're talking to patients, and it gives you a taste of what it's like to be a doctor. So I've decided to do a quick slide on the UK medical training system. I know not everybody here is from the UK, but when I was at your stage, and even when I was at the point of leaving med school, I didn't really understand how it works. So I thought it might be helpful to break it down for everybody. So you leave medical school, you then become an FY1 and then an FY2. And that's your foundation training, which is essentially like, I think in other countries it's equivalent to being an intern, where you work in a bunch of different jobs. You do 3 different jobs a year. So each one is 4 months. You rotate through different specialties. Gives you a really good taste of, what it's like to work in this department and that department and that department. And it's a great opportunity for you to start getting a taste of what it's like to work in each specialty. The course that you then take depends on what you want to do. Let's say you want to be a cardiologist. You would then go into core training, in this case, core medical training. You do that for 3 years, and then you would go into specifically the training of the thing that you want to do. So cardiology training in this instance, and then you become a consultant. Let's say you want to be a brain surgeon. You'd go into core training, but this time it would be core surgical training. You'd do that for 3 years, and then you'd go into specifically neurosurgery training. My path was different to that. I wanted to do paediatrics. As Lavinia said, I figured out quite early on that I really enjoy working with children, much more than I enjoy working with adults. Paediatrics is something called run-through training. And the idea is you don't need to do a core block where you do, get a good basis in medicine or get a good basis in surgery. All I need to do is to be able to work with children. So they do run-through training for that. And that's an 8-year program. Just change it to 7 years. But so that's a 7 or 8 year program where that is all you do. And then you become a consultant. And then you can go on and do extra bits and pieces. I'm happy to get this slide back up at the end because personally this would have really helped me, but in the interest of time, I'll move on. So what have I done so far? So as I mentioned, in F1 and F2, you do a variety of different jobs. So in FY1, I did geriatrics, which is elderly medicine. I did intensive care and acute medicine, which was one of the most interesting jobs I've done to date. And I did urology, which I didn't love, but it's very, very interesting. FY2, I did paediatrics, and that's the stage at which, before that, I thought I might want to do paediatrics, and doing it really, really cemented that. I then went on to do cardiology, and I did some more cardiology. I was meant to do A&E in my last job in FY2, but as this was in 2020, and as some of you may remember, things were a bit unusual in 2020. And then I did an FY3, and I decided to, so FY3 isn't on the the little career slide that I showed, it's essentially a year outside of training. So you take a step outside of the system and you essentially do a year doing whatever you want to. And I wanted to improve my application for paediatrics, get some more experience, really know what I was signing up for. And luckily I loved it. But I did a whole year working in paediatrics and it was an amazing experience. ST1, ST stands for specialty trainee. So at this point, I am specialised in peds. So I did 6 months of neonates, which is babies, and 6 months of general paediatrics. In ST2, I did 6 months of tertiary neonates. Tertiary means, so neonates can be divided into 3 levels, level 1, level 2, level 3. And tertiary essentially means the sickest babies, the tiny preterm babies, the 23, 24, 25 weekers, the babies who are really, really struggling. And that was an incredible experience. I worked at the hospital that has the most extreme preterm deliveries of the whole of London. And I got great experience of what it's like to work with really, really sick babies. And then I did 6 months of hematology and infectious diseases, which I loved. Those, as I said, I did my bachelor's in infection and immunity. And this was a really good job to sort of take some of that weird and wonderful science that I learned and see how that actually works in patients. So I was very grateful for that opportunity. Which brings us to today. I'm currently working at Chelsea and Westminster Hospital doing paediatric accident and emergency, which I think it's fair to say, of all the jobs I've had so far, this is my favourite. Every day when I go into work, I am excited to do it. And I'll talk a bit about my current job. But it's hard to take you through a day in the life because no 2 days are the same. And that's something that I really enjoy. You go in and you have no idea what you're going to see that day. You could literally see anything. But I thought to give you a bit of a taste of what it's like to work in A&E, we talk about some cases. And I've got 2 cases, which I'm going to take you through. I've got some questions, but in the interest of time, just think about the answers. Some of them are quite medical and there's no reason that you should know them at the moment, but some of them are also kind of common sense-ish. But yeah, let's do some cases. And these are cases that could genuinely walk into any A&E in the country at any time. So case 1, you're a doctor working in Peds A&E. A 2-day-old male baby is brought in by their mother. The parents called an ambulance because the baby appeared blue and was struggling to breathe. So you ask some questions, and it turns out that mum did not attend any screening during her pregnancy. It was a normal delivery. Immediately after birth, the baby was well, and it was discharged a day later from the postnatal ward. Every baby in the country will get a baby check. And this baby, the midwife was doing it, heard an extra sound in the heart, which is very, very normal for babies. So she booked it into a clinic next week to be seen again. Fine. So baby comes in, you look at the baby, it is very blue. Babies should not be blue. Babies should be lovely and pink. So you do some observations on the baby, you take its vital signs, and you see the heart rate is 180. This is too fast. the numbers in the brackets are the normal range. So a normal baby should have a heart rate of approximately 120 to 160. And in these cases, if the heart rate is 162, fine, we're not really worried. But this is much too high. The respiratory rate, how fast the baby is breathing, it should be taking between 40 and 60 breaths every minute. This baby's taking 90. It's breathing way too fast. The oxygen saturations, this is how much oxygen is in the baby's blood. A normal baby should be above 94. We would get worried if the baby is at 90%. We'd be very worried if the baby is at 85%. This baby's at 75%. This is very, very bad. And this explains why the baby is blue. So this is not good. And the temperature is normal. Fine. So what next? Have a think. What would you do next with this baby? You've got a very sick baby in front of you that has low oxygen levels. What would you do? So you need to resuscitate the baby. This is a very sick baby. You need to do something quickly. And in medicine, resus being resuscitation, is very easy. You need to know 5 things, and those 5 things just so happen to be the first 5 letters of the alphabet. So, A, airway. If the baby doesn't have an open airway, they're not able to get any oxygen in and out. They're going to die very quickly. You fix the airway, life saved, easy. If the airway is open but they have a breathing problem, this is, how fast are they breathing? They're getting the oxygen in. Are they exchanging gas across the lungs? So how fast are they breathing? What are their oxygen saturations? Are they working hard to breathe? Is someone panting away? It looks like they're really struggling. You look at those sorts of things. Their airway and breathing are fine. You move on to C, which is circulation. Their airways open, they're getting oxygen into the lungs, and they're exchanging oxygen across the lungs. The next thing that needs to happen, the heart pumps that oxygen-rich blood around the body, delivers it to the tissues that need oxygen to survive. So here we're looking at things like blood pressure, heart rate, colour. Is the baby pink? Are they pale? Are they blue? Things like that. D stands for disability, and this is brain things. This is like, are they alert and active? Are they unconscious? Are their pupils reactive? What's their blood sugar? Things like that. And the last step is exposure. You need to fully expose every patient, because if you don't, you're going to miss so much. You're going to miss the florid rash that tells you that this baby has meningitis. You're going to miss the bruises that tell you so much information about where this baby's injuries are, etc. So, in this case, A, airway. The airway's open. The baby can breathe. They can get oxygen in. Fine. Breathing. They're tachypneic, which means they're breathing too quickly. Remember, the respiratory rate was 90, and we should be aiming for somewhere between 40 and 60. They're desaturating. Their saturations are low. We need to do something about this. So we put on a face mask that delivers high flow oxygen. Fine. Circulation. They're tachycardic, and they're cyanosed. Cyanosed is a fancy way of saying they're blue. Disability. So I said we're looking at brain things. So PEARL stands for pupils equal and reactive to light. You shine a light in baby's eyes, their pupils are the same size and they constrict when you shine a light in, which is exactly what they should do. We're happy. They're moving all their limbs. We're happy that there's no focal neurological deficit, and their blood sugars are 5.4, which is normal. and we fully expose the baby. We don't see anything. So we've done our initial A to E, and we've made a change. We've done an intervention. We've started oxygen. So now we need to go back to the top and see what this has done to the patient. So we're on high flow oxygen, and SATs go from 75 to 78. And you'll remember that I said that we're aiming for above 94. So 75 to 78 is a little bit better, but it's still not much better. And the respiratory rate remains high. So now we need to think. We've done the easy A, B, C, D, E. Now we need to think, what is the problem? How do we fix it? And in this patient, it comes down to one question. Is it a B problem or is it a C problem? Because you'll remember the baby's breathing quickly and they're desaturating, but you remember that I covered cyanosis, which is being blue, in the C part of the A, B, C, D, E. So we need to think, is it a B thing or is it a C thing? And in this baby, just so happens to be a circulation problem. When you're working with children, you see common things. You see chest infections, you see, tonsillitis, you see all sorts of everyday things, fine. But you also need to be alert for the one case in 100, in 1,000, whatever, that is something weird and wonderful that the baby was born with. And this just so happens to be something weird and wonderful. So this baby has congenital heart disease. Congenital meaning something you're born with. And it's a cyanotic heart lesion. So cyanotic means it turns you blue. And without going too deep into the science of it, anything where you deliver... So your heart is meant to pump oxygen-rich blood to your body. Anything where you don't do that, where you pump oxygen-poor blood to the body, will turn you blue. And there's a few different types of cyanotic heart lesions. These are those. Very conveniently, most of them begin with T, making them very easy to remember. And these are all very weird and wonderful, and most people see these a couple of times in their career. I'm not going to go too deep into the explanation of any of them except for the top one, because in this case, this is what the baby has. So, transposition of the great arteries, TGA. Quick explanation of how it works and why it does what it does. I'm going to assume a basic level of understanding of how the heart works. The right side of the heart, blood returns to the right side of the heart. This blood has just been to the body. It's got very little oxygen in because it's been off around the body delivering oxygen to the tissues. Right side pumps it to the lungs. It picks up oxygen. It comes back to the left side. It gets pumped around to the rest of the body to deliver that oxygen. Comes back to the right. Rinse and repeat. The blood vessel coming out of the left side of the heart that delivers oxygen-rich blood to the body is the aorta. The blood vessel that comes out of the right side of the heart that delivers blood to the lungs to pick up oxygen is the pulmonary artery. In TGA, those two arteries, the aorta and the pulmonary artery, are switched. So you can see what happens here. The pulmonary artery comes off the left side of the heart. The aorta comes off the right side of the heart. So oxygen-poor blood that's been off in the body delivering oxygen comes back to the right side of the heart. And then it goes straight back through the aorta to the body. So you're never delivering oxygen to the tissues that need it. Hence your oxygen saturations are low, because the blood is just, it's not picking up any new oxygen. So you can see how this is a problem. And this is the issue with this baby. It's why it's blue. It's why its SATs are so low. It's why it's working really hard to breathe. It's desperately trying to deliver oxygen to the blood, but it's just not getting there. And this is very serious. Luckily, some very clever surgeons can do a very clever operation, which is called a switch operation, which is exactly what it sounds like. They take the arteries and they switch them around. Easy. So this baby's going to be fine, but they came in very sick, and we had to resuscitate them, make sure they were stable, and find out what the problem is. And that's the key with working in A&E. In any case, you see a patient, you fix the immediate problem. Are they dying? Am I watching this child desaturate in front of me? Are they going to stop breathing in a minute? And then, okay, we fixed it. Let's start to think about why they ended up in this situation in the first place. So that's A&E. Do one more quick case before we move on to the rest. This one is much easier and much more common. TGA is very, very rare. I think I've seen one case in my career so far. One, maybe two. But it's very interesting when you do see it. So, case 2, you're a doctor working A&E again. A 16-year-old girl comes in. She's recently returned from her holiday in Nigeria. She now presents with fever, muscle aches, and headaches. So she's obviously unwell. You look at her and you notice that her skin and her eyes, the whites of her eyes, are not so white. They've got a yellow tinge to them. Have a think. You have one question. You have one question to ask. That's the make or break in this case. Have a think. It's fairly obvious, but think about it. So that question is, did you take anti-malarials? Nigeria is a malaria endemic country, and it will depend on the area in Nigeria that she went to. But so you need to find out where she went, but this is the key. Did you take anti-malarials? So you ask her and she says, no, I forgot to pack them, which happens a surprising amount. So this is malaria until proven otherwise. So we need to investigate for malaria, and then if it is, we need to start treatment. How do you investigate for malaria? There are a few ways, but the gold standard is you look at the blood. You take a blood sample, you smear it out on a microscope slide, you dye it, and then you look at the cells. So on this slide, the pink circles are red blood cells. The purple thing in the middle is a white blood cell. What does malaria look like? Let's have a look. You see the difference. There are loads of little purple dots. Malaria is caused by a parasite. That parasite is called Plasmodium. There are various different types, but Plasmodium, very helpfully for us, lights up nice and purple on a microscope slide if you apply the right dyes. So it's very easy to see. You take a blood sample, you smear it out, you look at it. Do they have malaria? Yes, no, easy. This patient has malaria, and they have a lot of malaria. This is a very high parasite burden. So we're going to start treatment. Without treatment, this patient is going to struggle. But again, we've done exactly what we need to do in A&E. We've seen a sick patient. Are they going to, collapse in front of me? Yes, no. In the case of TGA, yes, resuscitate. In the case of this, no. they're not going to collapse in front of you. They're going to collapse in the next couple of days. So we need to find out what the problem is. We do one easy blood test and we diagnose the problem and we can start treatment. Wonderful. That's why A&E is very satisfying. You see something, you fix it. So that's the bulk of my talk done. They asked me to talk about what I do differently, and I struggled with this because I don't know. I think the big question is if I could go back and talk to I decided that I wanted to do medicine when I was 14. And if I could go back and talk to my 14-year-old self, what would I say? Would I still do medicine? Yes, absolutely. I genuinely think, knowing my personality, I think I'd be bored doing anything else. Like I said, this is a job where no 2 days are the same. You go in and you don't know what you're going to see. You could see 20 cases of tonsillitis. You could see 20 cases of the common cold. Or today could be the day that you see someone with something really serious. Today could be the day that you get a returning traveller who didn't take their antimalarials. You know, every day you could see something weird, you could see something wonderful. And I love it keeps you on the edge of your seat. And I don't know what else I would do. Going through uni, I had an amazing experience in uni. There's not much that I would do that is different. I chose to do infection and immunity for my bachelor's. I would do the same again. It's so interesting. And in my career, if I have to do one thing differently, I decide to do peds sooner than I did. And then I could start gearing my CV towards that, I guess, which is very doable at a late stage, but I had to sort of scramble a little bit to make sure that my CV was up to scratch. So that's what I do differently. Nothing too major. I love my job. I'm so happy that I do it. So thank you all so much for listening. I hope it's been useful. I did a whistle-stop tour of a couple of potential cases that I could see, tomorrow. I could go into work tomorrow and see them. Apologies if I had to speed through the science, but I think it gives you an understanding of why medicine is structured in the way it is. You do the basic science, you learn the anatomy, you learn the physiology, and then you apply it. And it's really good to have that basic background to fall back on. You can go back to first principles and figure out what is wrong with any patient that you see, essentially. So
thanks so much, Hugh. That was great. There's some really lovely thank yous coming in the chat for you, and people were following along all the time with their reflections and insights into the cases that you were talking about. So thanks so much, everyone, for participating in the chat. There's literally gazillions of questions for you, Hugh, and we're not going to get through all of them, but if we take them by the ones that have been most upvoted, and just jump in. The first is from Alicia. Sorry if I'm not saying that right. Alicia's question is, would you say that studying medicine at Oxford is much harder than at any other university?
No, it's different to some other universities. So the courses in the UK, sorry, everything I say is going to be fairly UK centric because that's where I've studied, it's where I've worked. I don't really know, I don't have experience of studying in another country, essentially. In the UK, courses are split into two types. There's PBL, which is problem-based learning, which is kind of like what we did today. You take a case, you work through it, and then you see, okay, this is the patient's problem. Why do they have this problem? Let's look at the science behind that. Or you have the way that places like Oxford, Cambridge, Imperial, UCL do things, where they give you that basis of very pure science. And that, so Oxford do that. You do a science degree and then you do clinical school. And like I said, I really like the basis that that gives you. But if you go to other universities, you'll get a slightly different experience. I don't think it's harder. I think everywhere you're going to be a doctor. Right? Maybe at Oxford you have a little bit more, I don't know, work outside of lectures to do, but they're all making you a doctor. They all have a basic level of knowledge that they have to give you. So it's hard, but I don't think it's significantly harder than anywhere else.
Got you. Great. Thanks, Hugh. Good question, Alicia. Okay, great question from Dana. And this is also echoed in a few other questions below. How do you deal with the mental aspect of working in paediatric care?
It has its moments. Most of the time, the reason I like it is that most of the time it's a very happy specialty. The people are very happy. The kids are cute. They're running around, laughing, playing. It's great. Every now and then you get that one case. And we actually had one on Friday, which was not so happy. And the baby was fine, but the way that they got sick was quite distressing. And it does hit. But that's part of being a doctor, I'd say. If you work with adults, you're going to work with elderly people. You're going to be making decisions about end of life care. You're going to be, we worked through COVID, like we saw awful things. In pediatrics, most of the stuff you see isn't awful. And then every now and then you see the one awful case that makes you remember the dark side of it. It's tough, but you learn to cope, and I think talking to each other is the most important thing. You're all human. Everyone in the department is human. We all get affected by things, and you just have to be able to talk to each other and help each other out.
Right. Thanks, Hugh. Hopefully that helps, Dana. Rithvik's asking if I can read from the bottom as well. I can, but I'm going to try and choose the most upvoted questions because we're not going to get through all of them. So the next one is from Pippa. Before medicine, were there any other options you were considering? And if so, what made you go in the direction of medicine? You did speak about this a little bit beforehand, didn't you?
Yeah. Before I wanted to be a doctor, I wanted to be an actor. That was the only other career I really thought about. That's when I was like 13 or something. And who knows, maybe it was a wasted opportunity. Maybe I could be famous in Hollywood by now. But no, I decided on medicine quite an early age, 14. And I pursued it because, like I said, I did the work experience and I realized that it is something that I think I could do. And I'm very lucky in that it worked out well for me.
Great. Okay, thank you. Quite a lot of questions around applying to Oxford specifically for medicine. So top tips for applying to Oxford specifically.
Oh, goodness. It seems so long ago. I don't think it's drastically different from other places. I think the exam that you have to do, for most universities, you have to do the UKCAT or the UCAT, which is the entrance exam for most medical schools. For Oxford's, you have to do the BMAT, which is a slightly different exam. I'd say slightly harder. It focuses more on science and actual knowledge than sort of lateral thinking that the UCAT tests. You do the entrance exam, you need to do reasonably well. I think do your research, know what you're applying for. Like I said, I don't think it's harder than other medical degrees, but I think it's different to some other medical degrees. And I applied to 4 medical schools, and Oxford was the only offer that I got in the end. And I think that's because I was suited to the course was suited to me. So know what you're signing up for and check, would it be the right fit for me?
Thanks, Hugh. Good advice. And for all of you, Alicia says, wow, that's amazing. For all of you who have lots of questions around university applications, we've got a university applications panel after lunch. Yes, there are changes coming to the BMAT, Amrita. Thank you. So we've got a university applications panel after lunch all around this exact question. Okay, I'm really conscious of the time, Hugh, but we've got a lot of questions on work experience. So Adila, for example, how exactly did you get the work experience? Did you just stroll in or apply through some other method?
I essentially strolled in. I didn't stroll in, I called up. I basically cold called the local university or the local hospital. Like, hello, I want to see medicine. Can I come and do some work experience with you? And they said yes. They directed me to the right person, and I popped in. While I've been working, we've had lots of school students coming in to do work experience with us. So yeah, there's no super easy in. I think you just have to, grab it, take the opportunity, call up somewhere, say, hi, can I come in? And most places will have a person who is able to arrange that. And we're all super happy to have students come in and shadow us and see what it's about.
Brilliant. So don't give up. If you're finding it hard so far to get work experience, keep taking initiative and pick up the phone. Great. Okay, I'd like to, possibly a good place to end, Hugh, is, we've got so many questions. I'm really sorry that we can't get through all of them. Omar seconds Hugh's advice, definitely phone rather than emailing. Leon says it's very hard. The other thing, and I'd be remiss if I didn't plug this, we have research internships in medicine at Oxbright, which you can sign up for. The next one's running in November. So if you're struggling to get in-person work experience, join us for a research internship. You'll research a cutting-edge aspect of medicine. And from there, if you're still sure that you want to do medicine, then you can look for practical work experience in hospitals. Okay, final thing, Hugh, just to wrap up. One word of advice for the 15 to 18-year-olds that we've got here, aspiring doctors, and also kind of a sub-question to that. I'd love a book recommendation from you. We're actually collating a list of book recommendations from our speakers today. So best recommended book and overall top tip.
There's so many good books, though. Overall top tip, I'd say it's hard, but it's so worth it. And if it's what you want to do, then don't get demotivated. Remember that it is a great job and you're doing it because you love it. And it's really worth the hours in the library, the 3-4 hour exams, all the nonsense that you have to do. At the end of the day, you're doing it because it is a great job. Book reference, the one that I read, or one of the favorite ones that I read, was Complications by Atul Gawande, and he's a surgeon, and he talks about so many interesting aspects of being a surgeon and the reality that he works with day in, day out. It's hard to describe, but definitely worth a read. If you haven't read it, definitely check it out.
Thanks, Hugh. Wonderful. Okay, thanks so much to all of you. We've also got students recommending When Breath Becomes Air, Paul Kalanithi. Great, thank you. Students, do feel free to pop your own book recommendations in the chat as well, and we'll be collating student book recommendations for a reading list. Okay, a huge thank you to Hugh. That was so insightful and interesting. I'm really grateful for your time, and there's some thank yous coming into the chat for you. I wish we'd had time to get through more of these brilliant questions. To everyone watching, thank you for all the questions. Do keep submitting questions throughout the day, and we'll always run through them. There were 107 questions for you, Hugh, today. So students are very curious to hear all about your life and work. So Hugh, thank you so much. I'll pop you back down as an attendee and you can jump off the call if you need to. But thanks so much for coming. And what I'll do now is I'll hand over to my co-host Omar for our next session.